Good evening, everyone. Thank you for joining us for our conversation today on substance use disorders. I'm really excited to take on this topic because it's one that I don't know a lot about, and I want to sort of have more of an understanding of how substance use disorders impact women and how treatment options may be different for us based on the stresses and other unique challenges women face on a day-to-day basis. So I'm really excited to have Lauren Grawert, who is a board certified addiction psychiatrist and the chief medical officer of Aware Recovery Care, with us today, as well as Vasanta Pundarika, who is the CEO of Lotuspring. I will turn it over to them in just a moment, but before I do that, for those of you that aren't familiar with me, I am Priya Bathija, CEO of New Health. And for those that may not be familiar with New Health, we are a company that is helping healthcare leaders understand how they can expand services for women who are their patients, who live in their communities, or who serve in their workforce. So we're doing a lot of exciting things, but one series we started from day one is the What's New series, and we frequently have episodes that cover different issues in women's health. And the hope is that we will engage in honest and educational dialogue, and that we will all learn a little bit more about our health, our wellness, and what we should be paying attention to as we move forward in our day-to-day lives. So just to make you aware, in case you have not seen, there is a new documentary that has been released called The M Factor. It is the first documentary to address menopause, and it features 12 leading experts on menopause. For those of you that don't know, there are a lot of things that can be different in our lives as women. We can choose to have kids, we can choose not to have kids. We may have different health concerns. But menopause is the one universal female experience. It is something that will happen to all of us if we have ovaries. So an estimated 1.1 billion women globally will experience menopause by 2025. 2 million women in the United States enter menopause each year, and 85% of them will experience menopause symptoms. So I highly encourage that everyone watch this film. And it's not just for women who are in perimenopause, menopause, or postmenopause. It is for every woman to understand the changes that will happen in your body, whether you like it or not. It is also for the men in your lives and the men who have joined us today, because this is something that will impact your life as well as the women you love enter this phase of life. So you can watch it on your local PBS network on your television or at pbs.org. So wanted to make everyone aware of that. And with that, I will turn it over to Vasanta and Lauren.
Thank you so much, Priya. I'm also really excited about this conversation. I'm the CEO of Lotuspring. I work with companies that are filling in gaps in healthcare for women by advising them on their financial goals and capital strategies. And I was a healthcare investment banker for 18 years before this. And it was really the gaps in healthcare for women that I was seeing in brand new businesses that people were building in behavioral health that still were not catering to women. That is what really started opening my eyes to looking at women's health as a space. And then I started seeing the giant gaps all across all of women's health, right? Which is all of our healthcare from our tops of our heads to the bottoms of our toes. And so, Lauren, this is really the space that really got me into this in the first place. I'm excited to be talking to you about this. But can you tell us a little bit more about your background, what you do, and what an addiction psychiatrist actually is?
Thanks, Vasanta. So I'm Lauren Grawert. For those of you who have not met me before, I am an addiction psychiatrist. That's a physician who goes to medical school, specializes in psychiatry after that, and then further specializes in addiction psychiatry. I always wanted to be a doctor growing up, but I never thought I would become a psychiatrist. I thought that was not medical enough until I really fell in love with the biological aspect of it. When I was in doing a general psychiatry residency, This was really as the opioid epidemic was fully unfolding. I was working at a large VA hospital in the South, and I just kept seeing so many people with psychiatric conditions who were struggling with a serious substance use disorder. And so I said, I feel like I could be a better doctor if I could treat the substance use disorder part better, which led me to do a fellowship. Really passionate about addiction psychiatry. So now I'm the chief medical officer at a company called Aware Recovery Care. We do in home addiction treatment. And a lot of what that looks like is prescribing medications for people who struggle with alcohol use disorder, opioid use disorder, among others, both to help with their physical withdrawal symptoms, as well as to help reduce long term cravings.
What made you want to work with a company like Aware that does that kind of in-home care, which is a more unique model, I think, in substance abuse treatment?
Yeah, a great question. So, my first job out of fellowship was at a very traditional large HMO. So, kind of your traditional brick and mortar outpatient, come in, see the doctor, get admitted inpatient, or do outpatient treatment. And while that was a good experience, it was quite frustrating because there are so many barriers to addiction treatment for women. And so, what I was finding was a lot of women who were really sick with their substance use disorder but were telling me, "Look, Dr. Grawert, I can't go inpatient for detox because I have
Mhm.
3 kids and I'm the only provider." Or, "Oh gosh, Dr. Grawert, I really want to do this intensive program, but I'm the sole breadwinner and my kids are depending on me." And so what I found over and over in more traditional medicine was there were so many barriers to women getting treatment for addiction that Aware was a really nice change for me because Aware, we do virtual treatment, we're coming in person into the home. So we're removing all those barriers that traditionally women face and also focusing on whole person care. So we have a whole family component for our patients where they have a family therapist for their family member or ally. We get to family psychoeducation. So it really does treat addiction more comprehensively, lowering barriers to care in a way that I have really never seen done anywhere else in medicine for addiction.
Mhm. So when we're thinking about substance use disorders and women, you were just talking about barriers to care. But if we take it back a little bit and just talk about, substance use disorders, everybody suffers from them, right? Men and women. But what is different about women and their reaction to alcohol or other substances? And how do these disorders kind of impact women differently?
Yeah, so this is like a fundamental thing that's important to understand. If you take a female and a male and start them drinking at the exact same age with the exact same quantity and frequency every day, what you will see is that the female will progress quicker to physical dependence and
Mhm.
will progress quicker to the long-term negative outcomes of alcohol. We call that telescoping. There's actually a real term for it. So if you Google telescoping and addiction, a lot of information on this. And there's a lot of real biological reasons why. The first is that alcohol is actually fat and water soluble, and women have less water density in their body than men. So that alcohol that you are intaking is more concentrated, much more concentrated because we have less water per total body mass than men. The second reason is that women have less of the alcohol dehydrogenase. Women have anywhere from 50 to 75% less activity of that enzyme. So we're kind of playing two different ball games here when you're talking about your body's ability to break it down. So the lethal limits and the higher toxicity happens much faster in women because we don't have the same amount of that enzyme. And then the third reason why women are more vulnerable is that actually our sex hormones, estrogen and progesterone, highly affect our vulnerability to alcohol. So if you're taking a female who's ovulating or menstruating, because her hormone levels are different on those days, she's actually going to be more vulnerable to the acute effects of alcohol. Same thing with menopause, as menopause starts changing hormones levels as well. So it's that combination of lower enzyme activity, lower water to body mass index, and the vulnerability of our sex hormones that really makes women much more vulnerable to the long-term physical impacts.
So if we're more vulnerable to the long-term physical impacts, then does that also make us more vulnerable to getting addicted?
Yes. 100%, both from a psychological perspective and from the just pure physical aspect. So not only that, but what you'll see is that women develop the long-term consequences of alcohol much sooner than men. So we see much higher levels of liver cirrhosis in women who've had the same consumption as men. We see much higher levels of alcohol-related cancers in women. We see much higher rates of alcohol-induced hypertension or high blood pressure in women related to men. There's about 60 different acute and chronic disease states that are either caused or exacerbated by alcohol. And in all of those cases, unfortunately, women are developing those alcohol related health disorders sooner and quicker than men.
So if we're talking to what, women, I think a lot of women are going to be listening to this. What do you think women can be doing to kind of better prepare themselves against the risks of, the symptoms of alcohol, reactions of it in our bodies, as well as the addiction risks and recovery?
Yeah, I think one thing is just try to make facts based on data.
Mhm.
So what I would recommend to women listening, one of the best books that summarizes all this data that I've read as a physician is called Beyond Booze.
Mhm.
It's a great mix of data related articles and kind of personal memoirs that women give. But look at the data. The data is really overwhelming that no amount of alcohol is safe for women. The second thing I would say is don't underestimate the power that media has on marketing towards us women. Media has really shifted over the past 20 years. It used to be almost exclusively marketing alcohol towards men. And as women have entered and I would argue dominated the workforce over the past 20 years, that marketing towards women for alcohol has become more intense and more competitive and more influential, unfortunately. So don't underestimate that. I see it everywhere. And then finally, I think what I would say to women is don't underestimate the effects that alcohol have despite the lack of appearance. So meaning that unlike with cigarettes, people's voice starts getting gravelly, they
Mhm.
get wrinkles earlier, their teeth turn yellow. With illicit drugs, there's a whole range of physical changes you see. With alcohol, it's really deceptive because people can have low to moderate amounts of drinking for years and years and years and not see that physically. I think for women, and I would include myself in this category, it's really hard to think of a substance like alcohol that doesn't show physical effects and still try to remember, hey, even though I don't look any different, this consumption is dramatically increasing my risk of cancer. So just remembering, kind of being aware that there is a really big discrepancy there between lack of physical changes, but these high risk consequences still happening at the same time with alcohol, which kind of makes it unique.
Yeah, I mean, you were just talking about the marketing campaigns. I think, for years, possibly my whole life, I've been marketed to that, smoking kills and, it's going to cause lung cancer and all these things and big labels all over cigarette packets. But I don't know that I quite appreciated what the effects of alcohol were as it relates to cancer until I started working in this industry.
Yeah, I mean, so we know the American Cancer Society has definitively come out and said that alcohol increases the risks of at least 7 different prime cancers. For
Mhm.
women, I think one of the ones, so liver cancer is on there, throat cancer, mouth cancer, esophageal cancer, colon cancer, but breast cancer. We know
Mhm.
that breast cancer is already the most common cancer globally. It's also the most common cancer in women. 1 in 9 American women will get it. And even low to moderate drinking, which is defined as about a bottle of wine a week, is still going to increase your risk of breast cancer by more than 15%. I know probably everybody listening knows somebody close to them who has had breast cancer or died from breast cancer. My own mother had breast cancer, my mother-in-law, countless friends I've known. So remembering that it increases the risks of cancer, but it really dramatically increases the risk of the most common cancer that we end up succumbing to is just a sobering reality to keep in mind.
Yeah, and the thing is that you don't want to be seen as, the party pooper,
Yeah.
when you're walking around, marketing these things. But at the same time, there is so much marketing about how fun it is, and not that much marketing about, the risks of cancer.
Yeah, and I think not to vilify a specific alcohol maker, but I'm going to do it. Coors was probably the first company that really mastered and targeted going after women for alcohol. If you remember Zima Zima came out in 1993, I think it was. Really Coors targeting this wine cooler, fruity, low calorie drink specifically marketed towards women. One of my best friends was a marketing executive at Coors in Denver for a long time. And she tells me stories of sitting around these tables with their marketing folks trying to think of a way to advertise to women and not have it be too overt. So Coors real I mean Zima was one of the highest selling alcoholic beverages of the 1990s. They really kind of busted the door open on, I think, the potential, the economic and financial potential that women had, and most of the other large manufacturers followed suit after that. And I think it's just women, we just have to recognize that. That is very intentional. That's a very intentional switch to target women. And you see that as that media has gone up, the health related outcomes have increased almost directly. There was a great 2017 study, one of the best ones, I think. It was called The Feminization of Alcohol Marketing. And it showed that between 2003 and 2013, there was almost an 83% increase in the diagnosis of alcohol use disorder in women. And that was almost directly correlated to the increase spending media marketing the alcoholic industry had towards women.
And specifically developing products that were more attractive and exciting to women as well.
Exactly. Exactly.
Mhm.
Yeah.
And I mean, Bria was talking earlier about the M Factor film, and you were talking about estrogen levels as well. I've seen a lot about, you know, things that you need to worry about in your diet as you're going through menopause. And one of the things that seems to be pointed out over and over is really, watch your alcohol consumption because of those estrogen levels that you were talking about earlier.
Yeah, absolutely. I mean, alcohol consumption will very well-known studies showing that increased alcohol consumption will exacerbate the symptoms of menopause, both in the severity that women experience it and in the length of time, the chronicity. The other thing about diet is that alcohol really dysregulates blood sugar levels.
Mhm.
And so anybody, as we get older, we are more predisposed to developing type 2 diabetes. Anybody who has a vulnerability or a family history of type 2 diabetes, alcohol intake is going to exacerbate that because it dysregulates insulin levels. It also leads to stronger food cravings. So, people who struggle with food addiction, as alcohol intake goes up, food addiction and food craving intensity will increase as well. I will say there are some simple foods that folks can try to integrate into their diet to help regulate insulin levels, which in turn decreases alcohol cravings. Things like nuts. Nuts have a lot of protein that keep blood sugar stable. Cinnamon. Cinnamon is something that I put cinnamon in my coffee now every morning. It's shown to help regulate blood insulin levels as well and blood sugar levels. And the more stable you can keep your blood sugar levels, the less that alcohol cravings and thinking about alcohol is really a factor.
That's exciting. I love cinnamon. So this is that's fun to know. I'm gonna start putting it on everything too. Maybe not a cinnamon covered donut. That's probably not going to be, providing the same effect as what you were talking about.
Maybe they'll equal each other out. I mean, you got the sugar there, but some cinnamon on there to equal the blood sugar. I like that.
Exactly right. We've been talking about the biological differences between men and women, and how alcohol impacts women differently than men from a biological perspective. At the beginning of COVID, there was like a big dip in a lot of the clients that I had at the time, substance use disorder companies, seeing a big dip because of all of the state regulations and everything happening. And then coming out of those state regulations, they were able to fill up a lot of their men's units. And it's mostly residential care, right? But they were not able to fill up their women's units. It took a lot longer. And I got asked this question over and over again by multiple different clients, why is this happening? I don't understand. But it was so obvious to me, being a woman, that there were all these logistical issues associated with that. I think for this audience, if we could first talk about some of the different treatment models that are out there for substance use disorder, and then start talking about how Aware's approach is different to try to combat some of those logistical issues.
Yeah.
Because I think we're talking about a sandwich generation, right? Women with a lot of caregiving issues and jobs and all kinds of other things going on. I'll let you talk about it though.
Yeah, I mean, so you're so right. So, addiction treatment 101 in a like 30-second version is that there are about four major levels of care depending on your severity if you're doing traditional treatment. So there's outpatient. That's if you think of going to see your doctor every couple of weeks, virtually or in person. Then there's an intensive outpatient, which is seeing a physician or a provider about 3 times a week, about 9 hours of care. There's a lot of IOPs that are virtual now. The next level from IOP is PHP, which is partial hospitalization program. These are outpatient, still outpatient substance use disorder treatment that's usually daily, every single day of the week. And then the highest level would be an inpatient, either a residential, like a traditional 30-day stay, or being admitted to a hospital. So typically, if somebody's doing a traditional model, they're meeting with a doctor, and the doctor is trying to decide, okay, can this person do an outpatient care or do they need to go to the hospital? The great thing about Aware is that our program really spans an outpatient level of care and an intensive outpatient level of care. So you're getting pretty comprehensive care that spans several different levels of care in a way that we are able to treat folks with pretty severe substance use disorders. And so the way that benefits women is, like you said, if there's so many women who are in sandwich generations where they're caring for their elderly family members, they're caring for children, they're holding down one or two jobs. Most of those women, it's impractical to be able to go to an inpatient level of care. It's also a lot of times, financially, not feasible. So we're able to treat people in those lower kind of almost hybrid levels of care, and we treat folks for acute withdrawal, so alcohol withdrawal we do outpatient, and I think we're probably the only people in the country doing virtual alcohol detox. And we do virtual opioid detox. We prescribe medications for co-occurring disorders. So, meaning if you have a substance use disorder and a psychiatric condition, which is pretty common, depression plus alcohol, maybe anxiety plus opioid use disorder, we treat both of those conditions. And then we really prioritize bringing in a family member or an ally that a patient wants to help them through the process. And so I have found it incredibly rewarding because there's just so many more people we can treat because we're lowering these barriers. And I would say it disproportionately benefits women because, to your point, they don't have to worry about these barriers. We meet with people in the nights, we meet people on weekends, almost any time of day. We kind of let them create their schedule of when they can meet. Instead of a doctor saying, "Here's when you're gonna come, here's the time, here's when you need to be here," we say, "What works for you? What can you do? Let's start there."
Yeah, I think the phrase is, trying to provide treatment without interrupting patients' lives. And it's a lot harder to interrupt a woman's life for a lot of logistical reasons. And of course, we're generalizing here, but it is a huge barrier to care.
Absolutely. And the other thing we do differently that is really being more and more promoted by SAMHSA and NIDA and NIH is we really prioritize harm reduction and moderation management approaches. So what that means is, there's a growing group of both women and men who might have concerns about their alcohol consumption, but they're not ready to quit. Or maybe that's not ever their goal. They want to moderate how much alcohol they intake, or at least want to start with that goal. A lot of traditional addiction treatment providers would say, no, if you're going to come see us, we're abstinence only. It's an all or nothing. Come back when you're ready. We prioritize meeting people where they're at. And so if recovery for you looks like decreasing your alcohol intake from a bottle of wine a day to a glass of wine a day. We want to help people with that too. There's incredible amounts of health benefits with simply decreasing alcohol intake, even if people are not stopping. And there's also medications that are FDA approved to be pretty efficacious in reducing alcohol cravings, even in the context of continued drinking. So we really pride that ourselves in that, and I think that's the way addiction care should be, right? Is really a patient centered approach where the patient is dictating what do they want recovery to look like for them versus the other way around.
Well, I think in this space, there's so much fear. And, for a lot of the patients, they're kind of living in a space where it's hard to even admit that there is an issue and that they need to get care. And so if you open the door a little bit and make the track into care a little bit easier, that's a huge barrier that you've then removed as well.
The fear is several fold. Women and men alike, they're fearful of treatment being dictated maybe in a way they don't want, but they're also
Mhm.
fearful of judgment, right? I mean, addiction, unfortunately, is still an incredibly stigmatized disorder. And we really take a non-punitive, non-judgmental approach when our patients have and our women have recurrences or relapses as they're sometimes called. We treat it as a learning opportunity. We say, and we're proactive about that. I like to say to our patients at Aware proactively before even starting treatment, hey, recurrences can happen. Addiction is a chronic disease. It's part of the learning process. If or when that happens with you, we want to be able to talk about it. We want to use it as a learning opportunity. We want to hear from you. What did you learn out of that recurrence that will be helpful in us helping you moving forward versus looking at it as a punitive, dirty thing, and proactively kind of giving that positive, unconditional regard, a message of, we're going to be here supporting you and caring about you, regardless of what happens, really is much needed in addiction treatment. And I think a welcome relief to a lot of patients who have not had that similar reception in traditional healthcare.
Do you find that that approach actually helps you deliver kind of a higher quality of care across all your programs since you're in multiple different states, right? And most of what you're doing is very virtual, but you're trying to meet the patients where they are and bring them in and bring them along for the journey. And I guess how do you make sure that you are delivering a high quality of care given that that's your model?
Yeah, good question. So, we really heavily rely on the American Society of Addiction Medicine's levels of care. So, ASAM, which I'm a member of and very active, has kind of very spelled out what their recommendations are for levels of care based on symptom severity. So when we meet with patients for the first time at Aware, we'll do a 90-minute assessment that's based on those ASAM levels that will pretty concretely tell us, hey, this is your recommended level of care. And the levels being the ones that we talked about. I think the thing that makes us different is that we're not afraid to do a level of care if it's still medically safe that might be different from what ASAM recommends. It might be based on what the patient wants. And
Mhm.
ASAM has even asked providers to start focusing on this new dimension called patient-centered considerations. Like, okay, I might need a inpatient level of care, but I can't do that because I have kids. Sometimes even if somebody would be, let's say, better suited to a higher level of care, as long as it's still medically safe for us to do a lower level of care, we'll just document that. And that I think to your point helps us to provide quality care that
Mhm.
is based on our standardized up-to-date medical guidance, but to more people, provide it to many more people than would otherwise be able to reach that care. And that's how we kind of juggle quality with low barrier care.
Yeah. Do you find that there are reimbursement challenges with that, or is that outside of your wheelhouse and you want to focus on the actual care?
I mean, the short answer is yes. I think there's reimbursement challenges in this heightened kind of, I call it payer power. The payers, the insurance companies have lots of power there. There's always challenges to reimbursement. We're just playing two different games sometimes, that motivations can be different. But I will say, like, I work pretty closely with a lot of our payer relations, and most of those folks are pretty reasonable, and they're open to, if I give them a call and say, "Hey, you denied this CPT code, but here's all of our documentation." They're reasonable.
Mhm.
It is a sometimes tedious, frustrating process, though.
I mean, it's complicated, right? When you're talking about, two diagnoses that are fairly similar, but you're recommending a very different treatment approach, and especially with what you're doing, because you're also recommending a different treatment approach based on where the patient is as well, and based on what you think the patient needs and where the patient is. And so, two patients that are presenting very similarly, you might be recommending completely different things for them. And so, to get that through the reimbursement process is more complicated. I think that's a barrier throughout all of substance abuse treatment, all of behavioral health, frankly. When you're thinking about, reimbursement and as well as like other types of policies and procedures, what do you think is one of the barriers, or if there aren't really any, to expanding in-home treatment? Because it seems like the approach that you're taking is better suited for women, and therefore, I hope that it continues to get expanded across the country by Aware and others to follow suit. But what do you think are some of the barriers to what you're doing?
Yeah, I mean, I'd say the biggest barrier is educating state regulators on the safety of in-home addiction treatment, specifically the detox part. ASAM and NIDA and SAMHSA tend to be ahead of the curve. I mean, they're recommending the most up-to-date medical information, but state regulators sometimes are years behind, years behind. And so, one of the biggest barriers that I struggle with is trying to educate state regulators and reinforce that things like virtual detox are safe and effective. Sometimes there's regulations that are pretty outdated. With all respect, they're not based on the newest medical guidance and recommendations. And so antiquated state regulations is a big one. I would also say the DEA to some extent. The DEA can be a barrier. The DEA looks at controlled substances through the lens of diversion, which I understand that's their job. I mean, the heads of the DEA are attorneys. They are busy prosecuting the two biggest drug cartels in the world in Mexico. So sometimes they have, I think, good intentions, but a skewed perspective. And because of that, we've seen, the telehealth flexibilities during the COVID era have been kind of extended. We think they're going to be extended another 2 years, but there hasn't really been a path to permanent telemedicine flexibility, which leaves providers like us in limbo land. Those are the biggest barriers are educating our state regulators and quite frankly educating our leaders at DEA on how safe, effective addiction treatment with controlled substances is possible and should be continued.
Yeah. I do think it's a long, long road ahead, but it does feel like there have been some changes and some strides being made, on the policy side, state regulator side, on the reimbursement side as well. Maybe one day we'll actually have a mental health parity act that's working. Uh,
Yeah, that's great because it certainly exists on paper, but as you and I well know, there are lots of ways that folks try to get around that in sneaky ways.
I've got some questions here from the audience for you. Do you see any correlation between substance abuse and other like undertreated, underdiagnosed female conditions like endometriosis, PCOS, autoimmune diseases, chronic pain, things like that?
Oh, absolutely. So any disorder, any physical disorder that changes people's weight
Mhm.
or changes their experience of pain typically dramatically increases their vulnerability to addiction. And so the autoimmune conditions and even chronic pain and fibromyalgia are two really good examples there where people have just different higher low experiences of pain that can make them more vulnerable to self-medicate with, fill in the blank substance. With PCOS, we know that there is to some degree a correlation with weight there as well. And so, mentioning kind of going back to the blood sugars there, as people's weight fluctuates, which happens with PCOS, their insulin levels fluctuate, which is also going to make alcohol and substance use disorder cravings more noticeable.
Mhm. Are there stats around, men or women being more likely to die or recover from substance use disorders?
More likely to, you mean kind of women versus men there?
Mhm.
Well, we know there are stats that very unequivocally show that women are more apt to seek treatment for addiction. That's a good silver lining. We've talked about a lot of negatives, unfortunately, with women addiction, but the silver lining is that women, by far and away, seek treatment at higher rates than men do. We could speculate on that a lot. I think there's a lot of good reasons for that, but that's the good, is that women seek treatment quicker and usually more proactively than men do.
Okay.
Now, whether that translates to real decreases in death, that I think that remains an open question. But at least we know that women are seeking treatment at higher rates than men are.
That's one of the big positive things you've said here. That's huge.
Yeah, yeah, and I think we could speculate on that, but I think unfortunately, in American society, male masculinity is associated with strength and
Mhm.
not showing what's considered to be weakness. And sometimes that men can perceive, unfortunately, addiction as a weakness. Whereas I think with women, we're just naturally, and maybe I'm generalizing, but naturally more communal with each other. We're naturally more help seeking in a good way. And so that translates to real benefits when it comes to seeking care. But it would be
Mhm.
fascinating, I think, to look at, to your point, does that translate to reduced morbidity and mortality?
Does that community seeking help with treatment as well? Because I think a lot of substance abuse treatment is about, not feeling alone and being part of a community where people are feeling similarly.
Yeah, absolutely. I mean, addiction is a disease of isolation by
Mhm.
far and away. And that's why we saw the numbers, skyrocket during COVID, quite frankly. Never in our nation's history have a time when we had to intentionally isolate. I think women are just more naturally communicative, communal, help seeking with each other. One crazy stat I read about COVID is that during the height of COVID, there were 6,000 deaths per day from COVID.
Mm.
Alcohol, on the other hand, causes 8,000 deaths per day. Yet during the pandemic, alcohol ABC and alcohol delivery was still considered a essential service, which to me was so crazy. Like, okay, more people are dying a day of alcohol than COVID, yet we're still gonna like give free access to it. But back to your point, yes, I think women being more communal helps with their recovery chances in general. And we see at Aware, because we focus so much on getting family involvement, friend involvement, ally involvement, in general, that's a much easier conversation with women. I mean, it comes naturally to them. They're like, oh, of course, yes, I want, my mother to help me or my coworker. Men, sometimes it's a tougher sell. I think at least that can help us in terms of being naturally more communal. For sure helps in the recovery process.
Yeah. This question is about, AA and AA being patriarchal, if not more on the misogynistic side. So I think that's someone's experience with AA. I have heard that from other people as well. But do you see other successful programs working for women who are alcoholics or suffering from substance abuse disorder? And I find this question interesting because I think that a lot of the programs that have been developed over the years, and if you go to a lot of the conferences in this space, it is very male centric. And we have seen a huge rise in women suffering from substance abuse disorder, alcohol use disorder. And so it's exciting to see that there are programs being developed with women in mind, given that rise. But the question from the audience is, do you see any other successful programs working for women?
Yeah, yeah, great question. So, back to our friends at NIDA and NIH, they did a fascinating study in the 90s and the 2000s called Project Match, where
Mhm.
their question was, what is the best type of therapy for addiction treatment? What's the best, meaning what's the most efficacious? 10-year study. And they had a cohort that was in AA, they had a cohort that was in general supportive psychotherapy, and they had another cohort that was getting cognitive behavioral therapy, which is just a more structured form of thought-based therapy. And so they followed these groups, and they had men groups and women groups. They followed them over 10 years and then looked to see who did the best with their recovery outcomes. It was so funny. I was in one camp, like the AA people were like, 12-step program is going to win out. And the like really artsy psychotherapists were like, no, it's going to be supportive psychotherapy. But what they found in the end was that actually every single program had pretty much equal efficacy rates. The one distinguishing factor that was more indicative of somebody being successful was the relationship they had with either their individual therapist or the community group therapy. And so I take that as a physician, the way I use that is when I'm talking to patients, I say, what has worked for you in the past? What have you heard about? What do you like? What do you don't like? What kinds of approaches do you like? Because the reality is that the one that the person is going to stick with and they're going to feel most comfortable is really the one that's going to work. And so to that end, of course, there's the 12-step model, but there are some great CBT based, cognitive behavioral based approaches for women that are for addiction. So, smart recovery is one of the biggest ones that's non 12 step based for addiction. Smart recovery has women only groups. And then, of course, supportive psychotherapy as well. The last thing I will say, though, too, about just about AA is that with women, I always recommend if they're going to do a 12-step approach to go to a women's only group. If you go to AA's website online, you can search by a women's only group or a man's only group. They even have, I mean, it's gotten really sophisticated now. They even have like different ages of women's AA groups. They have, based on the time of day, early sunrise women's groups. So I think there is, unfortunately, sometimes you'll see some misogyny if it's a female going to a mixed group. But
Mhm.
the best way to avoid that if you're going to do a 12-step approach is just going to a women's only AA group.
Yeah, I always get worried when people say we only do this one thing. It's like, but okay, but the patient might not need that one thing. And it's more comforting to hear, here are the things that we do to treat the patients because the patient might need one of these other things. And, we're all very different as people. Sometimes it feels like in behavioral health, people want to make something work in a certain way, but we are also different as people that we need to make things work in a bunch of different ways. That's
Yeah.
my non-physician version of what you just said.
Yes. And I call that the buffet approach. That's what I'll tell patients is to your point, addiction is such a complex, multifactorial, faceted disease, and it presents differently in every person. And because of that, you're going to need something different from somebody else. And so it's certainly okay to do a mix and match approach where you say, you know what, like I like this part of AA, so I'm gonna take this part. Maybe it's the concept of having a sponsor, but I don't like the abstinence only stuff, so I'm gonna leave that aside. Cognitive behavioral therapy. I like the structured, concrete, thought based approach. I want to incorporate some of that. I don't want to incorporate the homework. Nobody likes homework with CBT. So I highly encourage people to really try all of them and just take the parts that they like or that work for them and discard the parts that do not work for them, as you said, the buffet approach.
Yeah. We got two more questions. Um, so we've talked a lot about the effects of alcohol on women and a lot about how a lot of us don't know about some of these effects that you've talked about today. So we're learning them for the first time. But one part of women's lives that we do know about the effects of alcohol is pregnancy. And so, during pregnancy, there is some SUD prevalence. And so, what are some treatment options there? What would you recommend to people?
Yeah, I mean, so that heavily depends on the type of SUD, I would say. For instance, when it comes to opioid use disorder, we know that medication assisted treatment, specifically buprenorphine and Suboxone, is very efficacious and commonly used during pregnancy. And we encourage pregnant women who have opioid use disorder that's moderate to severe to be on Suboxone or buprenorphine during pregnancy, after pregnancy. In that specific disorder, medications are recommended. They're safe. They decrease adverse outcomes during delivery. With alcohol, I would say we use medication assisted treatment during pregnancy to some extent as well. In my take home, women are always appropriately worried and concerned about medication use during pregnancy. But what I usually say is that, specifically when it comes to opioids, having high amounts of opioids in your system and then low amounts, high amounts, and low amounts, i.e., kind of untreated opioid use disorder, is incredibly dangerous and sometimes can result in miscarriages, placental abruptions, being on a medication assisted treatment during your pregnancy. The name of the game during pregnancy is stability. And so, even if you have Suboxone in your system, it's still keeping your physiologic system, your baby's physiologic system stable. In some SUDs, we use medications more than in others, but certainly they're always important. And medicating pregnant women's psychiatric conditions. So we have a lot of discussions about antidepressant use during pregnancy, the risks and the benefits there. The reality is that a woman who's on an antidepressant who has their depression treated has a much more stable and safer pregnancy than a woman with severe depression who is not on an antidepressant. So we have those conversations as well. Ultimately, given the autonomy, of course, to the woman to say, okay, taking all this into consideration, what would you like to do? But certainly giving them accurate information about the safety and efficacy of meds, both for behavioral health and addiction during pregnancy.
Yeah. As you were talking about the buprenorphine and all the other medication, that's exactly what I was thinking. It sounds very similar to a woman, trying to decide whether to stay on SSRIs during pregnancy, and that it's not one size fits all, but rather, every woman having a conversation with her physician to figure out what would work best because, stability is the most important thing, as you said.
Right, exactly.
How much do you know about the benefits of the vagus nerve support and improving vagal tone and more successful recovery?
So there are some vagus nerve stimulators out there. There's a couple different ones out now. I think maybe the most common one in opioid use disorder is Speranza. So these are, you know, devices, I would say, not medications, devices that are FDA approved to reduce the severity of withdrawal and opioid use disorder. My experience as a physician is that things like Speranza can be helpful in mild to moderate symptoms of withdrawal. With opioids in general, when somebody has moderate to severe symptoms of withdrawal, they usually need a little bit more than that. This might be a separate question. There's also some vagus nerve stimulation that's done for severe depression. And there's lots of research showing that, people can have vagus nerve stimulators surgically implanted to treat severe depression. That's usually kind of the last alternative because it's pretty invasive. But certainly we see some uses with opioid use disorder, some uses with severe depression.
We talk about a lot, just nationally, women live longer than men, but are spending a lot more of a portion of their life, many more years in poor health. And, being aware of everything that you've been talking about today, the increased risk of cancer because of alcohol, generally susceptibility to the effects of alcohol, and therefore addiction, and then the long-term effects of it on our bodies. I think all of those things, as well as just being aware of how it impacts, you know, later issues such as dementia and other things as well, I think can help a lot of people if we market it properly, as you were talking about earlier. Market it properly can help a lot of people not spend as much of their life in that kind of poor health, if you will.
Right. Right.
Um,
And that's the big question. If we market it properly, I always wonder, like, will there be a day when there is a cancer risk label on alcohol like there is for cigarettes? I mean, we have, of course, the teratogenic label on alcohol about pregnancy, but my hope is one day, we take this evidence and synthesize it and put it into use, to your point, with labels on alcohol that say this product causes cancer. I like to be an optimist, but I'm also a realist. I think that day is not in our near future, but certainly something we can strive towards and hope towards.
well, you kind of half answered my question because what the last question I was going to end with was, what does give you hope as we move into the future? And this label is probably one thing that gives you hope. But anything else? Because I think, it is kind of depressing to talk about this sometimes, because we do talk about, alcohol. We spent most of this conversation talking about alcohol because I think it's the one that's most prevalent. But, we're talking about substance abuse generally here. It does get kind of sad to talk about this sometimes. But we are making significant strides, in different approaches to treatment, creating virtual care models, in-home care models, everything that you guys are doing at Aware, just really bringing care to patients where they are at, meeting them where they're at. So it does feel like there's a lot of hope in this sector. But the labels aside, is there anything else that gives you hope?
Two big things give me hope, I
Yeah.
think. The first is the role that the GLP-1 drugs could and probably will play in addiction treatment. There's some great studies that NIH is doing in Baltimore right now showing that people who have obesity who are on a GLP-1 also have alcohol use disorder is having unbelievable positive results in also treating their alcohol use disorder. We're seeing that women in particular who are struggling with smoking cessation, a lot of times women struggle more because you gain weight when you quit smoking. So there's a big push to put women on a low dose of a GLP-1 drug to help with smoking cessation. The FDA just did a hearing on Capitol Hill last week about that and the role GLP-1s could play with smoking cessation. So hope one, I think the GLP-1s, if we can ever get them covered and the cost down, could really be a game changer for addiction treatment. And then my other hope I would say is that, we've talked a lot tonight about the negative role that media plays. But I think the positive thing that media has done over the past 10 years is really start to destigmatize addiction and show addiction in real empathic ways. And the most recent, I think, example of that is, a focus on Matthew Perry's death. There's been some great interviews with his family about his addiction struggles, about the strides they're making with some non-profits and charities. There's more and more television shows where you're seeing some pretty realistic portrayals of addiction in an empathic way. And I think that's the first real step to changing our society's view on addiction. And so GLP-1s, this more realistic, gentle, empathic portrayal of addiction really will help us get to a more comprehensive and complete and empathic understanding of how folks with addiction really function and should be appreciated in our society.
I love that. I mean, as you said, it is a disease where getting treatment involves getting over the fear of judgment and stigma and everything else. And so, I also read Matthew Perry's book, which was so real and so raw. And I agree with you. I think there has been a lot more empathic portrayal of the disease in TV and in movies. And that is exciting because it feels more real and it feels more like, hey, this is something that we should all be able to understand and start to help and support the people in our lives that are going through this.
Yeah, 100%.
You know? Priya, we'll give it back to you. Thank you so much, Lauren.
Thank you, Vasanta.
Vasanta and Lauren, thank you so much for that conversation. I know I learned a lot, and I learned a lot that I wish I had known when I was younger, right? Not at the not at the age of 46, but thank you for mixing the data, the medicine, the social context, and the treatment aspects together to bring us a more holistic view on the issue of substance use disorders and the risks for women. And thank you to Nadia Khan, who's New Health's policy analyst, for putting together the run of show and all of the event materials for this event. And thank you to all of you for joining us to have this conversation today. Next up, we have a conversation on fertility with Dr. Asma Ahmad, who is a reproductive endocrinologist and OBGYN, and she is the co-founder and chief medical officer of Carrot Fertility. That will take place on November 14th at 6 p.m. and stay tuned for more details. We'll also have our holiday book guide out very soon with books that you can purchase for your friends who you want to know more about women's health and feel empowered to make decisions for their own lives. So thank you all again for being with us tonight, and we will see you soon.